Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Dr. Maiken Nedergard won the Newcomb Cleveland Prize of the American Association for the Advancement of Science a few years ago for her work on the glymphatic system in sleep. Since that time, more work has been done examining the role of sleep in memory. An article was published in Cell on the effect of Zolpidem on the glymphatic system in mice. Dr. Natalie Hauglund is the lead author of this paper and is here to discuss her work and how hypnotics may adversely affect brain clearance. She is a Novo Nordisk Foundation postdoctoral fellow at the University of Oxford and the Danish Center for Sleep Medicine at the Copenhagen University Hospital. She previously worked closely with Dr. Nedergard for 7 years. So welcome. We appreciate you joining us today.
Yeah, thank you for having me here.
So I wonder if we can start at the beginning. And can you just sort of remind us about the glymphatic system and what we think happens during sleep?
Yeah, so the glymphatic system is the equivalent to the lymphatic system that keeps the rest of the body outside of the brain clean. So the lymphatic system is made up of a lot of lymphatic vessels, and their job is to keep the tissue clean from, for example, excess fluid or damaged cells, things we don't want to accumulate in the tissue because then it will become toxic. And for a very long time, it was a little bit of a mystery how the brain get rid of its waste because the brain does not have any lymphatic vessels. And that's where the work of Maiken Nedergard comes into the picture because they found that the brain has its own cleaning system that they called the glymphatic system. And the glymphatic system uses cerebrospinal fluid or CSF that flushes through the brain tissue. And when it does that, it mixes with the interstitial fluid in the brain, which is where all these waste products and waste metabolites are, and removes it all from the brain and transports it to the lymph nodes in the periphery. And what's especially cool about the glymphatic system is that it's more active during sleep than during wakefulness. Actually, when we are awake, there's almost no brain clearance happening. It's all when we fall asleep during night.
And so what is its function? Is it sort of for memory consolidation or is it like housekeeping?
Well, it's most likely more of a basic housekeeping function. So you can see it as on your trash that you have in your trash bin. If that was just allowed to accumulate and no one took care of it, it would be just really gross after a while and probably not very healthy to live in.
Probably not, yeah.
So we need someone to come and remove it. It's the same function that the glymphatic system has. Because if some of these, we know, for example, that amyloid beta is one of the metabolites that needs to be removed from the brain because accumulation can lead to buildup of amyloid beta, which we, for example, see in Alzheimer's disease. So we need this glymphatic system to make sure that the brain gets cleaned every night so we can wake up with a fresh and healthy brain.
So similar to the lymphatic system for the rest of the body.
Yeah.
So tell me about your study.
Yeah, so when we set out to do this study, we knew about the glymphatic system, and we also knew that there was a link between sleep and brain clearance, but we didn't really know what it was about sleep that was so important to sort of initiate the cleaning process. So that was our goal. We wanted to get behind the mechanism of glymphatic clearance. So should I just try to run through what we found?
Yeah, please.
Yeah, so to begin with, we were just really interested in finding out what is actually going on inside the brain with the cerebrospinal fluid during sleep, because the methods we had available until then, they weren't really we couldn't really use them to look inside the brain during sleep. So we had to look for some new methods, meaning that we actually developed a new method for this study that we called flow fibrophotometry.
Okay.
And it's based on a method called fibrophotometry, where you use an optic probe. So this was all done in mice. It's a tiny optic probe that you can implant in the brains of the mice. And after they recover, they can just move around freely with this probe in.
Oh, okay.
So the way it works is that if you shine a light via the probe into the brain, then if you have something fluorescent, like fluorescent tracer molecules, for example, then they will shine a light back that you can record. And we use this to inject tracer molecules into the cerebrospinal fluid of the mice, meaning that after we had injected these tracer molecules into the brain, the mice could just run around freely in their cage. They could sleep, eat, whatever they wanted to. And while they did this, we could in real time record the fluctuations of the cerebrospinal fluid.
Oh, that's very cool. Okay.
Yeah. So this sort of gave us a window into the brains of these mice while they were sleeping.
And so is this then you're trying to find like the mechanistic connection between sleep and the glymphatic system?
Yeah, that's basically what we set out to do. We had an idea based on previous studies that it's most likely something about the blood volume and the movement of the vasculature inside the brain. This was based on some human studies, for example, showing that during sleep there are these oscillations in the blood volume and in the CSF volume. So we thought maybe this would be a way that these dynamics of the vasculature can actually work as a pump to drive the cerebrospinal fluid into and through the brain.
That makes sense. Okay. So then what did you find?
Yeah, so with our method where we could measure these fluctuations in the cerebrospinal fluid, we used it in the same way to look at the blood volume changes. And we found that during sleep, there are these very slow, we call them infraslow oscillations, both in the blood volume and in the CSF volume. So roughly once every 50 seconds, there is a big increase in blood volume and a decrease in CSF volume, and then they turn around and go the other way. What we found was that we thought, okay, this has to be initiated by something. So we looked into the neurotransmitter noradrenaline, which had already been shown to also exhibit these infraslow oscillations, and found out that they all oscillate together. And by a lot of control experiments and a lot of experiments where we used, for example, optogenetics to manipulate the system, we found out that it's the norepinephrine is released in the brain in this infraslow pattern during non-REM sleep. And every time norepinephrine is released, it binds to the vasculature and it makes the arteries constrict. This creates this pumping function or pumping like mechanism of the arteries. So they constrict and dilate, which drives the movement of cerebrospinal fluid. So we basically found that the brain has its own pump almost, only during non-REM sleep that moves the fluid.
And it's driven by norepi.
Yeah, by norepinephrine.
Wow, that is really smart. Okay, so then what was your study? You did then a control and then Zolpidem?
Yeah, so Zolpidem came sort of at the end of the study after we had we had found this mechanism and we had a pretty good idea how it worked. So we wanted to look at how does this whole mechanism work in non-natural sleep, which is even though Zolpidem is a sleep medication, the sleep you get after Zolpidem is probably not the same type exactly of sleep as you get naturally, which was also something our results from this study showed.
And so tell me about the dosage. I don't know how to dose Zolpidem for a mouse.
Yeah, so we We used a bit higher doses than what you would normally see in humans, but the reason for this is that the metabolic rate in mice is way higher in humans. So, for example, Zolpidem is metabolized faster. If you look at the half-life of Zolpidem, it's around 20 minutes in mice and 1.5 to 3 hours in humans. So based on this, and then on a pilot study we did beforehand, where we tried to give different doses of Zolpidem, we ended up with a dose that was 5 milligrams per kilogram for the mice. So this was also the dose that had been used in a lot of previous studies. Based on our pilot study, we could see that if we gave the mice these 5 milligrams per kilogram, it reduced their activity, but they looked like they were sleeping, right? They didn't just pass out. If we gave them 1 milligram, it had a very small effect. So to be sure that we actually had a dose that would induce sleep, then we went with these 5 milligrams.
Oh, okay, that's cool. That makes sense. Okay, so let's take a short break, and when we come back, we'll talk more about the impact of Zolpidem on the glymphatic system during sleep. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Prepare for the future of sleep medicine at Sleep Medicine Disruptors 2025, November 14th through 15th. This hybrid course will provide a unique and virtual learning experience exploring the disruptive innovations altering the healthcare and sleep medicine landscape. Registrants can attend either virtually or in person at the Austin Marriott Downtown in Austin, Texas. Register today at aasm.org/events.
Welcome back to Talking Sleep. We're talking with Dr. Natalie Hauglund about her work on Zolpidem's effect on the glymphatic system. So when we were preparing for this, you mentioned that there was a microarousal every time the mouse had an oscillation.
Yeah, so this was one of the really interesting findings from our study that we didn't really expect to see. So yeah, every time we had this oscillation in the vasculature and in the CSF, we saw a microarousal. And actually, when we tried to correlate how well the mice, how good their brains were at clearing out the molecules we injected, we saw that the mice that had the highest number of microarousals were also the ones that had the best brain clearance.
Oh, so then arousals are important for brain clearance.
Well, we tried to look closer into this question, like, can it really be that the microarousals themselves drive the clearance? And based on our results, it seems like microarousals are a parallel product of the norepinephrine release. So every time norepinephrine is released to the brain, you both have this constriction of the vessels, but you also have a microarousal. So we sort of used it as a proxy to be able to see when there is a noradrenaline oscillation or norepinephrine oscillation.
So then how frequently do the microarousals occur? Is it also the same cadence? And is it only in slow wave sleep, or does it vary by different sleep stages?
Yeah, so at least in slow wave sleep or non-REM sleep, because that's the state where we have these infraslow oscillations in norepinephrine, then we see a microarousal roughly every 50 seconds, which is the cycle of the release. So it's not every time we see a release of norepinephrine that there actually is, microarousals, they look like tiny awakenings, but you just immediately fall back asleep. But sometimes there's only you can only see it in the brain activity, that is like the brain wakes up a little bit, but it's not, you don't have any muscle activity. But there are these small blips of wake-like state roughly every 50 seconds.
Well, so that's so interesting to me, because when we talk about arousals in sleep, right, I think we think of them as a negative thing, and that we want to change the arousal threshold by using medications like Zolpidem, et cetera. I kind of wonder if we've been looking at it sort of maybe not exactly right.
Yeah, I completely agree. I think microarousals are maybe a little bit misunderstood by a lot of clinicians. I mean, there's no doubt that you see more arousals with a lot of different types of pathology. I'm not saying that that all awakenings from sleep is a good thing, but we just have a lot of data that shows that these naturally occurring microarousals during non-REM sleep are actually just a completely healthy, normal thing. There's a study showing that mortality compared to the number of microarousals is actually a bell-shaped curve. So too few microarousals also are correlated to higher mortality as well as too many. So it really seemed like there is some sweet spot for microarousals.
A little bit of a Goldilocks
to be there. Yeah.
we see that with so many things in our field, right? There's sort of the sweet spot. So
exactly.
So is it the microarousals that drive glymphatic clearance?
No. So
okay.
As I mentioned, it's probably just this parallel mechanism where you have the microarousals, but it is a very intriguing question. This why are the microarousals there then? Because they must also have a function,
right?
That's something I'm looking at now doing my postdoc in Oxford. I got so curious about them, and when we did this the study about the glymphatic system, so I had to know more about them.
Well, it is very curious, right? I agree. And I think the other thing that I've really been trying to wrap my brain around is I read another paper that said that there was more glymphatic clearance during wakefulness than sleep. And that really I had to stop, right? I was like, hang on. Am I thinking of this the right way? Is that the opposite of what we've thought?
So the take home from that paper is the opposite of sort of the general hypothesis about the glymphatic system, because they argue that tracer clearance from the brain was higher in wakefulness than in sleep. So I think experiments studies like this they're really good because they they force us to really take a second look at our results and our hypothesis, and it also helps driving the field forward that you get challenged a little bit. Then if you ask me if I'm ready to throw the whole glymphatic hypothesis in the bin because of this one study, then the answer is still no. But I think it's interesting why we're getting these different results.
Yeah, tell me why. Is it different?
Yeah, so one likely difference between this and previous studies is the methodology. Okay. So in this paper, the main results are based on movement of tracer within the brain, that's not actual brain clearance. That's more movement from one place in the brain to the other. Another of the results show that the amount of tracer in the brain after a while, 3 and 5 hours, I think, after the injection is lower in awake mice, but they don't really quantify the actual removal of tracer that was there from the beginning. So it's just really hard to say anything for certain about this study. And then I should also add that as a response to this paper, the Nedergard group, they made a study which is on bioRxiv now, where they used phybophotometry to measure clearance of tracer from the brain to the blood in real time. And then they found faster clearance in the sleeping mice than in the awake mice. So it's definitely it's good with these counter studies to challenge the hypothesis we have, but I still believe that we have a glymphatic system that's active during sleep.
But I love your approach. I love that it's sort of, you take it as this academic challenge because we have this joint sort of goal of improving the science, right?
Yeah.
And the knowledge.
Exactly.
I love that.
We don't really move forward if we just sit and get angry and just
right.
if we don't get out there. And,
Completely agree. Yes. 2025 marks the 50th anniversary of the AASM. Please enjoy Dr. Chediak reminiscing about the growth of the AASM.
The major issues that affect sleep medicine today are fundamentally similar to those that affected it when I became a part of the leadership. Even when I joined the organization, they've just taken a slightly different perspective. So now we're talking a lot about artificial intelligence, and that's how we want to change things. When I was involved in leadership, it was how is home sleep apnea test going to change the field? When I became involved in the field is how are changing standards going to modify the practice of sleep medicine? So I don't think that the questions are very different fundamentally. So for me, it's always been about what is it that the country needs? What is it that my patients need? And how can this organization help my patients and the practice of sleep medicine grow?
Now back to our conversation. So all of this work is done in mice, right? So how do we extrapolate this to humans?
Yeah, that's a good point. So yes, our study was done in mice, and of course we need the human studies as well to make sure that we see the same biology in humans as we do in the mice. But we do have some studies in humans that give us an idea that it's very likely to be the same mechanism in humans. So first of all, I mentioned that there are these human imaging studies where they have also found these very slow oscillations in the blood volume and in the CSF volume during non-REM sleep. And it's roughly the same frequency as we see in the mice. So that's one thing that fits together across the species. And another thing is the norepinephrine. It's a bit tricky to directly measure norepinephrine in humans because you kind of have to be invasive and do something to measure inside the brain. But something clever that has been done to come around this is to use pupillometry in humans. And this is a method where you simply take a camera and point it to the pupil. And in this study, they did it in people that were sleeping. And the reason why this is so clever is that the pupils, they are sort of this mirror of the norepinephrine level in the brain.
Oh, no
so
way.
Norepinephrine makes the pupils constrict. So when the level of norepinephrine in the brain is high, the pupils are constricted, and when it's low, they're dilated. And when they looked at how the pupils were what they were doing during non-REM sleep, they saw that there was the same slow oscillation, so they were dilating and constricting in roughly the same frequency as we saw in the mice. So although this is not like exactly the same methods we use across the species, it still gives us a pretty good estimate of that we're dealing with the same kind of mechanism.
So they can do it through the eyelid?
I actually think they had some device to keep the eyes open.
Oh my gosh.
during sleep. Yeah. It's
oh my gosh.
Pretty, it doesn't sound too comfortable, but it's very impressive.
I was thinking initially when you talked about the thing that you put in the mouse brain, that's what they did for humans too. So I was relieved to hear that they don't do that. But now learning about this eye staying open thing, I'm not sure that's a whole lot better. So at the end of the day, you found that the Zolpidem decreased glymphatic clearance by 30%. Is that right?
Yeah.
So is that enough to make us change our practice?
Well, it's for sure it's a bit scary that we have this drug that we give to patients because we want to help them sleep.
Right.
And then we figure out that it actually might compromise the sleep that they're getting. So, of course, it's not a question about just stopping giving sleep medication to everyone. I think it's really it's a tricky question because a lot of people who are taking these drugs as Zolpidem, they simply just cannot get any sleep without it. And I still think some sleep, even with sleep medication, is better than no sleep at all. But I really hope that we can use this knowledge we have now to maybe go in and develop some new types of sleep medication where now we know what to look at. We can test our sleep medicine, see what effect does it have on the brain in terms of brain clearance. Because a lot of the sleep medicine we use today is a little bit like this big hammer that just goes in and hits everything and puts you to sleep. So yeah, that's one of the things that I at least hope we can use our study for.
You know what I also kind of wonder? I wonder if you could then develop a medication that enhances glymphatic clearance for the purpose of improving memory.
Yeah, that would be amazing, right? If we could just take a pill and then we could boost our glymphatic system. So that's definitely also one of the really cool things of the future, hopefully. I mean, now we do have some more knowledge for sure. We can maybe go in and target the norepinephrine release, or we could go in and target these vascular oscillations in the brain. So yeah, who knows? It would be really amazing if it could be used to develop something like that.
So did you get a million phone calls from people who take Zolpidem and are upset about your study?
There was a lot of people who contacted me because they were nervous about having, taken Zolpidem for a long period of time. And as I just said to you, I told them that they should, of course, like talk to their GP, but at least from my perspective, being not a doctor, I think that getting some sleep is always better than just being completely sleepless.
You're right? That's a conversation we have all the time in sleep clinic, that yes, there's risks of sleep aids, but there's also risks of not sleeping.
Yeah.
And you had sort of mentioned something before when we were preparing for this about how this really sort of shows us how important it is to beef up the other, non-pharmacologic treatment.
Yeah,
like
exactly.
CBTI, right? And there's so many barriers to CBTI. And one of them is sort of the unwillingness for people to do it. But maybe we do a CBTI light or something that's a little bit easier, because I think the sleep restriction part of it is scary for a lot of people.
Yeah.
And so,
Yeah.
but I think you raised so many interesting thoughts, right? Is it Zolpidem only? Is it all of the same sort of category of medications? Do the orexin-mediated medications work differently? There's a million questions.
Yeah. I think our study is just one step along this way of actually figuring out if there's anything that is maybe more beneficial towards the brain clearance, or what can we do? Like what would be optimal to do? Because people there, we will always have patients or people who cannot sleep. It's such an important process, but we just know so little about it still that it's really hard for us to to do anything. If it's like, if the brain doesn't want to sleep, it's really hard to tell it, you should just go to sleep.
Well, that's
so
it.
yeah.
It is such a hard balance, right? Because on one hand, we're like, well, sleep is super important. And on the other hand, we're saying, well, but I know you're stressed out about sleep, but don't stress out about your sleep. And so, I feel for our patients, because it is difficult to navigate between those two, right? You don't want someone to freak out about not sleeping, right? Yeah, but we know it's important. So then what's next for you? Is it the microarousal part?
Yeah, so I did get really, really curious about the microarousal. So that's actually what I'm working on now, trying to really dive deeper into the physiology, being really nerdy with like a lot of electrophysiology and sleep studies still in mice to try to get a better idea. I think it's so weird that we have this paradox that we see more arousals from sleep with a lot of pathology and with old age, but they're also just there in normal healthy sleep. So that's where I am right now.
I will say that is weird. Ever since we first talked about this, when I read sleep studies now and I see all these arousals, I'm like, well, maybe they're not so bad.
Yeah,
I'm like, I don't really know how to think of them anymore. If I see that their sleep is really fragmented, I'm like, okay, that one's not great. But if I see an arousal here and there, I'm like, maybe that's not such a big deal.
Yeah, exactly. I think it's because we don't know so much about them yet that it's easy to just whenever you see an arousal, then you can score it as something like that shouldn't be there. But so that's where I am now. Hopefully have another mystery solved soon.
So do you have a key takeaway for us?
Yeah, that's a good question. I mean, everyone knows how important sleep is, so I think that would be a boring takeaway to say you should get enough sleep, especially with this audience. But maybe a key takeaway from that I learned in the process of the study is that even if the results you're seeing just don't make any sense for a very long time, you should continue to try to dig deeper and actually make it make sense. Like when we in the beginning saw that glymphatic clearance seemed to be better the more awakenings the mice had, we were very confused.
Yeah.
And now it makes sense because we know it's because of the norepinephrine and everything. But if we hadn't just continued and trying to really get into why we saw what we saw, then we would never had made this study.
What a great piece of advice, though, right? When you're in the middle of something, it's true though. When you're in the middle of something, you're like, okay, this makes no sense. Like, if I done it wrong, then maybe it is just sort of like, well, how can it possibly make sense, right?
Yeah,
and then you stumble on something. That's brilliant. So thank you for joining us today and shedding some light on how Zolpidem may affect glymphatic clearance. I mean, you've really given us a lot to think about, and I hope your future work helps to guide drug development, but also the clinical guidance on the use of hypnotics. So thank you for being here.
Yeah, thank you so much for having me.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.